Well, welcome back. 15 minutes just flies. Our next speakers are Rihanna Pickering, Amy Purchase, and Ryan Vargas. And they're going to share local community services to support addiction recovery. But before I let them start, let me introduce them, please. So Rihanna Pickering is a dual board-certified family nurse practitioner and a psychiatric mental health nurse practitioner. She received her BSN from Lourdes University. Her Master of Science in Nursing is from Case Western Reserve University. And she received her psychiatric mental health nurse practitioner certification from Spring Arbor University. Rihanna has worked in Hillsdale since 2016, providing primary and psychiatric care to patients at a rural health clinic. She encourages wellness through education, encouraging lifestyle choices, medication management, and adhering to best practices. Rihanna is an adjunct instructor for the University of Michigan School of Nursing and a board member of Hospice of Hillsdale County. Amy Purchase is a certified peer support specialist and certified peer recovery coach for Lifeways. She currently works with the outpatient substance use disorder team, where she provides support and resources for anyone who may need assistance reaching their goals. She facilitates 2 groups and works with the contingency management team and promotes Lifeways services to the community. Ryan Vargas is the executive vice president and a therapist with MVA Behavioral Health Services, the organization that operates Hope House in Jonesville. He obtained his Master of Social Work with a concentration in mental health and chemical dependency, as well as his Bachelor's of Social Work from Eastern Michigan University. Ryan has 17 years of clinical service and provides individual and group counseling for clients with substance use disorders and co-occurring mental health disorders in outpatient and residential settings. All right. And I think, yep. Let me welcome them to the stage.
Okay. Good afternoon, everyone. My name is Rihanna Pickering, and I'm a nurse practitioner who works closely with individuals battling substance use disorders. I want to thank you all for being here today to talk about something that has touched nearly every community across this country: addiction, and more importantly, recovery. Let's start with an honest truth. Addiction is not a moral failing. It is a chronic, relapsing medical condition that affects the brain's reward, motivation, and memory systems. Just like diabetes or high blood pressure, substance use disorders require long-term management, support, and treatment. Yet for years, people struggling with addiction have been stigmatized, often treated as if they just needed more willpower or discipline. As a nurse practitioner, I've seen firsthand how wrong this approach is and how life-changing, compassionate, evidence-based treatment can be. What is medication-assisted treatment, or MAT? MAT combines FDA-approved medications with behavioral and psychosocial therapy to treat opiate and alcohol use disorders. These medications help to normalize brain chemistry, block the euphoric effects of opiates or alcohol, relieve physiological cravings, and stabilize body functions without the negative effects of the abused substance. While the ultimate goal of MAT is complete recovery, it has also demonstrated the following benefits. We have improved patient survival rates, enhanced retention rates in treatment programs, and increased capacity for patients to obtain or maintain employment. There are 3 FDA-approved medications for MAT: buprenorphine, Vivitrol, and methadone. Let's break down how each medication works. Buprenorphine, best known under brand names like Suboxone or Subutex, is a partial opioid agonist. This means that it activates opioid receptors in the brain, but only partially, enough to reduce withdrawal and cravings without causing a full high. Because it does have a ceiling effect, Even higher doses will not cause a strong euphoria, which lowers misuse potential. Buprenorphine can be prescribed in office settings by nurse practitioners like me and physicians and is often combined with naloxone to deter injection misuse. Common side effects include constipation, headache, and sedation, but it's generally well tolerated and much safer than illicit opiate use. Then we have Vivitrol, which is also known as naltrexone. It's an opioid receptor antagonist. This means it blocks the receptors entirely. If a person uses opiates while on naltrexone, they won't feel high or euphoric effects. It's ideal for individuals who've already detoxed, as starting it too soon after opiate use can precipitate withdrawal symptoms. Naltrexone also helps reduce cravings in heavy drinking days and alcohol use disorder. Monthly injectable formulations are offered to help improve adherence and reduce the risk of relapse. Then we have methadone, which is not offered in Hillsdale County at this time. It's been used successfully for over 50 years. It does bind fully to opioid receptors, eliminating withdrawal and reducing cravings for up to 36 hours. Because it's a full agonist, it can produce dependence, but when administered in regulated opioid treatments programs, it's incredibly effective. Studies have shown that methadone maintenance reduces opioid use by over 60%. In overdose mortality or death by up to 75% compared to no treatment. It's typically dispensed daily in a clinic until patients have achieved stability. What is the typical length of treatment? The duration of MAT medication really varies from months to years. It often requires long-term use to prevent relapses in patients. How do we know MAT works? MAT has been studied for decades. The data is clear. It cuts the risk of overdose death by more than 50%. It improves treatment retention, meaning patients are more likely to stay in recovery programs. It reduces transmission of infectious diseases like HIV and hepatitis C. It improves overall quality of life, allowing people to work, reconnect with their family, and contribute to their communities again. I've watched patients who once couldn't make it a day without using substances go on to become parents again, students again, and workers again. That's what MAT makes possible. As nurse practitioners, we often sit at an intersection of medicine and humanity. We listen to our patients' stories, often filled with trauma, shame, and loss, and we remind them that they are still deserving of care and dignity. In MAT, my role isn't just to prescribe medication. It's to partner with my patients, to help them navigate withdrawal, cravings, mental health challenges, and the stigma that so often comes with this disease. We educate, we monitor progress, we collaborate with counselors, social workers, and peer support to ensure that our care is holistic. One of the hardest parts of MAT is fighting stigma, not just from the public, but sometimes from the medical community itself. I've heard people say, they're just trading one drug for another, but let me ask you this. Would we ever tell a diabetic they're just replacing a sugar problem with their insulin? Of course not. MAT is not about replacing addiction. It's about restoring balance to the brain so that the healing can begin. These medications do not produce a high when taken as prescribed. They simply allow patients to function, to work, and to live. If we want to see fewer overdoses, fewer children entering foster care, and fewer families torn apart, we have to start treating addiction like the medical condition that it is. The future of MAT is exciting and the landscape is changing. Data waiver requirements have been removed, so all of us DEA-registered clinicians can now prescribe buprenorphine. Long-acting formulations are available, like Sublocade or Brixadi, a weekly or monthly injection, and that is expanding treatment adherence options. We have telehealth MAT services, which increases access, especially in rural communities like ours. We have harm reduction tools like fentanyl test strips, naloxone. They're now being recognized as vital components of comprehensive care. These are not small steps. They are system-wide shifts that make life-saving treatment more accessible than ever. For community members here today, your role is critical. Recovery doesn't happen in isolation. Patients succeed when they feel supported and not judged. Something as simple as offering encouragement, connecting them with local recovery resources, or advocating for harm reduction initiatives can literally save lives. For providers, physicians, nurses, pharmacists, and counselors, we have to work as a team. No one discipline can do this alone. We need more training, more MAT access in primary care and emergency departments, and policies that make it easier, not harder, to prescribe these medications safely. Medication-assisted treatment is not a quick fix. It's not a cure, but it's a powerful tool in the recovery journey. When combined with therapy, peer support, and compassion, MAT gives people their lives back. As a nurse practitioner, I've learned that recovery doesn't always look perfect. It's often messy, nonlinear, and full of setbacks, but it's also full of hope. Every time a patient walks into my office and says, "I haven't used for 6 months, I got my kids back," or "I finally have my life again," I'm reminded why this work matters so deeply. So to everyone here today, community members, families, fellow providers, I leave you with this: addiction is treatable, recovery is possible, and MAT saves lives. Let's work together to build a culture of care that replaces stigma with support and despair with hope, because every person deserves a chance to heal, and with the right tools, they can. Thank you.
You're just gonna hit this button right here.
Hi, everyone. My name is Amy Purchase, and I'm a peer support for Lifeways. Let's see. There I am. Certified peer support specialist, and I'm also a recovery coach. A peer support specialist is somebody who has had either a mental or substance abuse issue. I am an addict. I will always be an addict. I'm just sober. So today I'm gonna kind of just give you a rundown on what Lifeways has to offer for people with substance use disorder. We have peer support and recovery coaching. We have outpatient therapy, case management, psychiatric services. I'm gonna tell you how to get started, and I'm gonna give you a couple of other resources that I frequent, and some of my people that I see frequent. So a little bit about peer support. I started using drugs after my child was born. My drug of choice was methamphetamine. It was a quick fix to having energy, to losing baby weight. And to be honest, I loved it at that point in time. Little did I know that every day that I was using, it started to take over my life. And I started to lose who I was. I didn't like that feeling. It was very uncomfortable, but I didn't know how to get out of stop using drugs. It became a part of my everyday life, and if I didn't have it, I was trying to get it because I didn't feel like I could function. One day, I woke up after a 5-day binge, and my son was standing in front of me, and my face was basically suffocating in a plate of food, and I saw my son standing there asking me if I was all right. That's the moment I knew that I needed to do something, and I was out of control, and I needed to get back into shape because I had a little boy to raise. He was my motivation. He still is my motivation. He always will be my motivation. I fought the system. I didn't want to admit that I was a drug addict to anyone, not even to myself. I fought, I tried to do it my way, many, many times. Just never turned out that way. Judge put me in jail for a good 24 hours until I admitted that I had a substance abuse issue. Of course, after 24 hours in jail, I admitted it. Went to IOP a couple times, didn't get anything out of it. Went to AA, didn't get anything out of it. And I really thought I was a lost cause. I thought everything was hopeless. I had no more hope left. It was gone. I went to AA like I normally did, and I can't tell you what was said, but somebody said something and I correlated it with my life. And it was an eye-opener for me. I realized that I was a drug addict. And there's no shame in saying that. And so I made it my mission to do everything I could to get my life back, get me back. And I'm a little over 10 years today, and I've been offered such amazing opportunities to be a peer support. Peer support is everything to me. Helping others is so vital and important. I can't even stress enough. But watching someone grow from hopeless to hopeful again is better than any high I've ever received. And I can't imagine my life without it. Outpatient therapy. They offer counseling and education. We offer a variety of options for consumers seeking therapy for substance use and co-occurring disorders. Support is major in recovery. Everybody has to have at least one support in their life. So therapists also provide support for stress, anxiety, depression, and trauma. That's another thing with me. I didn't correlate my traumas with substance use. I didn't think that something so long ago could still affect me in my adult life. But I found out I was wrong. SUD assessments, we do screenings for addiction, assessments in coordination with probation, parole, CPS, and other services as needed. I run a group, and I have mostly drug treatment court participants in it. They're never happy when they first come in, never. But by the end, when they're ready to leave the group, you can see the turnaround, and they start to understand why things are the way they are in the program. Case management. Case managers can assist with employment, housing, education, receiving any kind of benefits that may be necessary, and activities. Psychiatric services. They offer psychiatric evaluations. We do medication and medication reviews, health checks. We offer MAT as well. We don't have all the things that Brianna offered, but we do have most of them, so they are options. And if we can't help you, we will refer you somewhere that can help you. We won't just leave you to try to figure it out for yourself. We also have a drop-in center here in Hillsdale. It's basically for mental health, but most people that have substance use issues also have some mental health issues, so we call that co-occurring. They do accept co-occurring as well. They do a lot of activities. They go out in the public. They take field trips. And it's just somewhere to go to have somebody kind of maybe facing the same things that you're facing to talk to, maybe to bounce ideas off of, or just a friend to have. We have some support groups in Hillsdale. It is no longer called Free for Life. It's Bridges to Recovery. It's at the United Free Methodist Church every other Monday from 6 to 8. It's my favorite meeting. It's very diverse, and it's very non-judgmental, and they have some great topics that they cover. So you can always make a friend there. Getting started at Lifeways, all you have to do is dial our access center number. We also have a 24/7 crisis line, so you can call anytime. They can pretty much walk you through with whatever you're dealing with, and it's great people on the other end. We have a national helpline for SUD, and we also have Mid-State Health Network SUD access line. So, a few more resources that I know of here in Hillsdale. The library. The library is a great place to kind of educate yourselves a little bit. I go there quite frequently with my groups, just because most of them like to look at books and read. We have 2 homeless shelters. They're not open right now 24/7, but they will be opening soon. One is the homeless shelter, Share the Warmth, is open on November 1st. And not sure about Camp Hope yet, but I'm hoping that everything will work out and that will open really soon. We also have the Salvation Army. We do a lot of group volunteering there with my groups. It's a way to help the community. And they also offer free lunch for anybody that might need a free lunch. And that's Monday through Friday. So. And then I have just a little quote. In the end, some of your greatest pains become your greatest strengths. Recovery is possible, and I am living proof of that. Thank you.
All right, well, I'm Ryan Vargas, as you can see on the slide here. I'm from MVA Behavioral Health. And so I wanted to share my appreciation for being invited to talk today. And I want to also share my gratitude for everybody that's in this room, because everybody that's here is here for a reason, to try to help our community and help the members of our community. You know, addiction is a very complex disease, and it takes a lot of people and a lot of different approaches to be effective. And so I always get very energized and appreciative when I see so many people come together for a common cause, because really that's what we need for things like this, is a lot of people on board trying to do the work that needs to be done to help the people in our community that need it. So a little bit about MVA Behavioral Health. We've been known as McCullough Vargas and Associates. That's how we started way back in 1990. The business was started by my father, Roy Vargas, and Gary McCullough way back then in Adrian and Lenawee County. We started off as part-time outpatient evening services, and over the years have grown to full-time outpatient in Lenawee County. We came here to Hillsdale County in the mid-2000s, around 2005, opened an outpatient office there. A few years later, we were approached by Hope House, which was traditionally a recovery sober house for men that had been operating since 1974. So it's as old as I am, 51 years, Hope House. And so we helped them with some management, we helped them with some treatment, case management, And that relationship grew to the point that we ended up buying Hope House, the property, the name, and everything else, and turned it into a residential treatment program for men, and then soon thereafter opened up a residential treatment program for women. And both of those programs are still operating today. And that's been the main focus of our business, over the last probably 10 years or so, 15 years. But we also have outpatient offices in Jonesville on the same campus that people can come to. So, we have a great treatment team. You can see here on the slide, there are therapists, peer recovery coaches, and case managers. And unfortunately, I'm noticing that I left out my resident aid staff. Our resident aid staff are one of the critical parts of our business. They're the staff that's with our clients, 24/7. And without them, our business would not be able to function. So I apologize to any of my RA staff that are here. A lot of our team is here right now, so I apologize for not putting you on the slide, but that's why I wanted to give you some extra kudos now. One of the things that we've been trying to do over the last few years, I came back to the business actually 4 years ago. I went and worked at Henry Ford Allegiance up in Jackson for 4 years, and then came back in 2021. So I've been back for about 4 years now. And since I've been back, our focus has really been on changing the business around, modernizing things, making things more effective, more efficient. And we've had a lot of staff turnover during that period. We did a lot of evaluation of our programming and just saw that, we could be doing things better. We've done things well and helped thousands of people throughout the years, but that's been one of our main focuses. And one of those focuses has been to really get people on board that are in recovery. Now, it's not a requirement to work to be in recovery to work for our company, but when you come to say Hope House and you're in the thick of it, you're maybe detoxing and really struggling, and you talk to that first intake person or that RA staff that's helping you get settled in, and you find out that, hey, that's a person in recovery too. And then you have maybe your first meeting with your peer recovery coach, and you find out, hey, that person's in recovery too. And then you talk to one of your therapists for your treatment planning and other sessions, and you find out, hey, that person's in recovery too. And then you find out that your program managers are also in recovery. And then you might talk to the owner one day that pops in and is running a group or doing something, and he lets you know that he's been in long-term recovery for 18 years. That really makes a difference, I think, in the minds of our clients, and it goes a long way. So that's been a focus too of changing the dynamics of how we treat our clients, right? It's been, we're trying to get away from that traditional model of, I maybe went to the slide too soon, but I'll get to that. We've had this traditional model of, you go to residential treatment for 28 days and you get out, and maybe you go to outpatient for a week or for once a week, and then those kind of things, and you see a therapist that's has a degree and has their thing on the wall and all that, which is important, right? All that stuff is important, but we're trying to really kind of grow our team. A lot of peer recovery coach focused. These are people that have lived experience. We heard about it earlier. That lived experience is so powerful, in the lives of people. We heard it earlier from Steve when he gave his wonderful talk, and that lived experience goes a long way when you meet somebody and they've been where you've been, and they've come out the other side and they're doing well. That really is motivation, and that gives a lot of hope for people. And that's what our business is built on, is hope. That's one of our slogans. It's up here on our mission statement. We believe where there is hope, there is recovery. Because if you believe that something can be done, you're much more likely to be able to do it. And when you see an example, a living, breathing example of people that have gone through addiction and recovery and are still in long-term recovery, that adds to that hope and that belief that it can be done for me as well. So I'm not going to go into so much of the vision and things like that. We're trying to be welcome and active and do more. This multidisciplinary approach, right? That's where we have multiple people with multiple specialties trying to help treat individuals and try to meet their needs. And if we can't meet their needs, well, we're going to refer them to someplace else. So, we work with Rihanna quite a bit for MAT services, because that's been a critical part of people's recovery journeys. We, refer out to Lifeways or wherever they might need, because again, like I said, it takes a village, right, to keep people in long-term recovery. Nobody does it in a vacuum. We all need people in our lives to make it go. And, and like it was talked about earlier, it helps me stay in recovery when I'm talking about recovery every day, and I'm coming to an event like this talking about recovery, and so everybody wins, in this kind of thing we do. So our outpatient services, I'm going to get back to that. Hope House is what we do. Residential treatment, it's a 3.5 level of care. So what that means is that's the highest intensity level of residential treatment you can have without being hospitalized. And so we do 40 plus hours, I say plus because the standard is at least 40, but we do more than 40 hours a week of treatment, both in core concepts of recovery and clinical treatment, and also life skills approaches because a lot of our clients need help in a lot of different areas of life. How do I cook dinner, right? How do I do laundry? How do I fill out a resume? How do I apply for a job? All these different things. So I tell our clients when they get there, this is a full-time job being here, 40 plus hours a week. That's a full-time job, and it's needed because, and that's one of the things that I was talking about earlier. We need to know that recovery is a lifelong pursuit, and addiction treatment needs to be longer and stronger for it to be effective. So we can't just go to treatment for 28 days and call it good. We can't just go to one time a week for outpatient. Maybe eventually we'll get there, right? And then maybe I don't need treatment at all, and I can just rely on my community supports or my self-help groups like AA and Celebrate Recovery and Smart Recovery and these other things that are out there. But kind of changing our mindset about what it takes to help people achieve and maintain long-term recovery. It's this very long-term engagement approach. So that's what we try to do at Hope House. It's a 90-day length of stay, which, it seems like a long time, especially for our clients when they first get there. And it is long, and it can be long. But 3 months goes by in the blink of an eye. And so, part of our job is helping people prepare for what's next. Because I tell our clients that all the time. As hard as it is to be in treatment and work on things and get started in recovery, this is easy compared to what you're going to find on the outside, once you're done with our programs. And so what we're trying to do, well, I'll talk about that in a second. So some of the things we do, the structured environment, structure, it was talked about earlier, is critical for all humans, but especially for people in recovery. And so having a structured, supportive environment where people can come and just focus on themselves and their recovery is critical. It's not easy, and people often, our clients will often try to find a lot of distractions, right? Reasons why they don't want to focus on self. And that's a big part of addiction. I don't like what I'm feeling. I don't like what's going on in my life. I don't like what's happening, so I want to escape from it. So we do assessments. Everybody has their own individual treatment plan. They're updated very frequently. I think it's every 2 weeks in residential right now. We do group and individual therapy. We do individual therapy, life skills training and education, and then the aftercare planning. That's a part of something that I had to wrap my mind around in treatment. As soon as you are admitted into treatment, you're already planning for discharge. It seems kind of counterintuitive, but everything we're doing along the way towards treatment is planning for somebody to complete treatment and then move on to the next thing. And so, so speaking of the next thing, that's one of the things that we're going to be focusing on soon, or next, I should say. A lot of my focus has been on revamping Hope House. We've got all new staff in place. We've got all new management in place. We're in a really good place right now with where that program is. And so then, the next step for us, and maybe I'll just move to next steps. So what we're trying to do, all of us, I think, in what we're trying to do is increase engagement for people, right? Improve individual recovery programs and outcomes, reduce hospitalizations and recidivism in the legal system. And then and why we're all here today is to strengthen this local recovery network, right? That's what we are here. Everybody look around. Hey, you want to know what your recovery network looks like, this is it. So what we're trying to do, kind of future vision, I want to touch on that more, because we do have outpatient offices, and it's unfortunately kind of not had much of focus, over the last couple of years, and so that's our focus now moving forward, is to expand our programming, expand our outpatient approach, maybe even finding a new location in Hillsdale County for outpatient specifically. We're going to be launching an IOP program, intensive outpatient program, which is, this is where you come to group therapy and individual therapy at least 9 hours a week. So usually that's in a format of 3 hours a day for 3 days a week, and then you see individuals and peers kind of in the meantime, and then that can lessen over time as you progress in that program. But again, this is what I was talking about in this longitudinal, long-term approach that we need to have for substance use disorder treatment and mental health treatment. The longer you stay engaged in treatment, the more intense your treatment is throughout that time. It's been proven to show that that's where the greatest outcomes are for long-term recovery. Okay, the longer we can keep people engaged, and how they stay engaged, that's going to be different. Residential, IOP, outpatient, individual, peers, maybe some just monthly check-ins, but having this long-term approach is really what we're looking for moving forward. Part of that's going to be trying to enhance this outreach in transportation. Transportation in small communities like Hillsdale County is lacking. It just is. The public transportation in Hillsdale proper doesn't even go to Jonesville, where our offices are. So hence the need for something that's closer to make it easier for people to get engaged in treatment. We also have telehealth services available that's another thing that we're trying to do, and that was one of the positive things that actually came out of the COVID era, right, was this online approach that we can do this telehealth and get people connected when they don't have a ride or they're too far away or whatever it might be, so they can stay connected. It's one of the biggest, most important parts of recovery, is staying connected with treatment, with your community, with your people, with your supports. And then we see on here restarting transitional housing. We've had different transitional houses over the years, recovery housing, and we've had varying levels of success. But I think we're at the point now that we're really ready to restart our transitional housing program. I was pleased to see on Facebook maybe a week or two ago that there's some other people that are trying to get transitional and recovery housing going in this county, and I'm very thankful for that. My idea about treatment and recovery and help is there can never be enough, right? So I don't look at anything like this as competition. I just think of it as more of good things that we can do for our community. So we're going to be really looking about property acquisition and starting a transitional housing program, so that people, once they're done with our residential program, or even if they don't need residential but still need supportive, sober recovery housing, that there's a place for them to go, because as we know, as we've seen, that is very needed right now. Homelessness is directly related to mental health and substance use disorders, and so it goes hand in hand, the treatment of SUD and mental health and homelessness and getting people housed. And so that's something that if we don't like it as a community, we just can't just brush it under the rug and hope it goes away and tear this place down and evict people from here and there. They got to go someplace, right? And so we're going to hopefully be one of those places that people can go when they need services, when they need housing. And so I'm really excited about that. Strengthening these community partnerships, that's another thing that I'm excited about. So I was excited to be here today, to see people and meet people. Some people I've seen before, some people haven't seen for a while, but kind of get reconnected back to this community. You know, a lot of my focus has been in Lenawee County as well over the last couple of years, but I'm excited to shift focus back here to Hillsdale County and get things going with what we have on board, and to hear more about what other people are doing and support other people in any way that we can, because we've got a great team. I'm going to brag on our team because I think we've got a great team in place. They're sitting at these two tables, at least part of them are right now. A lot of experience in a lot of different things, not just SUD. We've got people that have worked in schools. We've got people that have worked in juvenile justice. We've got people that have worked in all kinds of different areas that I think we can be very helpful if people want to reach out and give us a call, give us an email, you know, whatever it might be. So you matter at MVA, that's one of our mottos. You know, treating people, treating people like they're the most important client we have is important for us, because when people know that you care about what you're doing and how you're helping them, then they care a little bit more too. Because when addiction, anybody that's been wrapped up in addiction like myself knows that it's a pretty hopeless and helpless and pitiful place to be, you know, and oftentimes we don't care about ourselves, you know, when we're in the midst of it. But when you know that somebody that's trying to help you really does have your best interests at heart and cares about you and what you're going through, that matters. And we want people to know that that matters to us at MVA, that our clients matter, and everybody in here matters too, because we're all in this thing together. So there's our contact information if anybody wants to jot that down real quick, or see us after, you know, I think we're gonna have a table out here, so you can get one of our business cards or one of our flyers or anything else, and reach out anytime. You can call, you can email, you can go to our website. That's another thing, we revamped our website. You can get a lot more information on there. So with that, I'll say thank you.
All right, we do have time for questions again. We've got one right back here. Bella?
Okay, my question is for all three. You were talking about steps down to recovery like naloxone, the fentanyl strips and stuff. If the community were to put that stuff out and also have more rehabs, do you believe that, or even needle boxes, that it would allow people permission to use or bring people from the outside of the community here to use more? And I would like the answer from all three.
So I would believe that providing those resources would save lives. I think we are significantly, at least at our office, less concerned with diversion and more concerned with making sure people aren't dying.
If people are going to use, they're going to use, why not let them use a little bit safer than what they're using? It prevents so many more health issues. It could save a life, and that means a lot to me. I don't know about anybody else, but it's important. And we have a free box in the Hillsdale Lifeways. We have a vending machine for Narcan. I think there should be more of those in the community as well.
Yeah, I echo those sentiments. There can never be enough help. There can never be enough resources, you know, and, you know, as we, you know, this field is growing, it's evolving, and our ideas about what is recovery, about what is help, has to evolve as well. You know, when I first was in the field and in recovery, I was a big, you know, abstinence only and hardcore about that. And I still feel that abstinence is the healthiest way to work a recovery program when you're completely sober. And I also know that that's not always realistic for everybody that's in recovery, or at least starting their recovery journey too. And so we can have other resources available. We have, you know, MAT services. We have, you know, all these different things. The more of that, the more options we can have for people, the better outcomes we're going to have overall.
Here, Bella.
So I have two actually, and it's kind of to piggyback off of the question she just asked. I'm Katrina. I'm the Hillsdale director of the Drop-In Center. So I know I work firsthand with harm reduction. That's out of Jackson, and my first question would be, what do you think we can do as a community to amp up the access to harm reduction? Because I know there's only so much that they can do as a program, and that there's certain things they're able to distribute, and then there's certain things that they're not. So my question would be, what do you think we could do to be able to provide that full spectrum to our people?
I think some of the things we're doing now, like these programs, partnering, I'm thinking back 4 or 5 years ago when we didn't have any MAT services in Hillsdale County. I remember talking to a patient who was struggling with heroin use about Suboxone, and they said, I have to go to Jackson or further. They couldn't get it. So I think it's taking time, but we are moving in the right direction every day.
I agree with that, and I would say awareness, making people aware, maybe having some classes, just some education more on harm reduction. When harm reduction came out, I'm not gonna lie, I was not a fan of it. But it's convinced me that this is a healthier alternative to what people are doing, you know, to their bodies now. So I'm down for it.
Yeah, I echo those sentiments. You know, like harm reduction, you know, needle exchange program, you know, things like that. I think you're talking about, you know. It's hard for a lot of people that are not in this world and don't have experience to get their minds wrapped around how can you giving out needles to people be healthy? Well, the simple answer is, well, it prevents the spread of disease, right? HIV, Hep C, it improves health outcomes. It also, you know, when you have harm reduction programs, it gives an access point for people to get engaged with people, right? To have a dialogue. And maybe you're not ready to stop using, but you're ready to start using a clean needle. And then maybe after that, then maybe you're ready to try something else, you know. Maybe I'll go to that meeting. Maybe I'll have that intake appointment. Maybe I'll see what that's about. And maybe that one appointment or those series of appointments is what leads somebody to get into long-term recovery. So, you know, it is a changing minds thing, right? Because it can be counterintuitive. And I've been in that place myself before, you know, and looking at, we're trying to save, this is a life and death thing, you know. Substance use disorder is a fatal disease if left unchecked. And so the more that we can do to get people engaged and with resources and have a varying amount of resources available, the better we're going to be.
More questions?
I had one more. Sorry. Can I ask
yes,
it?
please.
My last question would be is, so like I know you mentioned the MAT. What is the barrier that we are not able to provide the methadone aspect to it?
We just haven't looked into it, honestly. We just started the Suboxone in the MAT program in the jail, like within the last 60 days, so that's huge. So I think one thing is resources, because I'm the only prescriber in the county outside of what they have at Lifeways. So resources basically would be the big one. It's nothing about belief or anything like that, it's just that we don't have a lot of people.
I feel like methadone is one that needs to be very well controlled. And I also, my personal feelings is it shouldn't be long-term if it can be possible to not. like she said, the resources just aren't here. They're not available to do that at this time, but hopefully someday.
Bella? Right at the back. Right at the back. No. Well, okay.
Thank you. Thank you, Bella. Well, thank you, Rihanna, for providing medication-assisted treatment in the county. Yeah, right. That should be a clap. Right. Thank you. And I'm interested. So, are the requirements to be able to provide medication-assisted treatment for medical providers, have those requirements changed? Are other medical providers just simply not initiating being able to provide that treatment? Like, I guess in your own words, what's your take on other medical providers in the county and the barrier of only having one prescriber in the county?
I think it's a knowledge deficit for the providers, right? They want to do it. I just talked to the ER within the last 3 weeks, and they want to develop a program where if somebody comes in and they're withdrawing, how can we start it until they can see me outpatient? So I think they're uncomfortable, maybe afraid what dose. They don't teach a lot of it in school. So to be honest, my first 10 years as family medicine, even when they removed the X waiver, I wasn't prescribing it. And then I went back to school for psychiatry, and I had a mandatory MAT rotation. And that's what opened my eyes really and made me fall in love with it. I'm like, we need this now. I love doing it. It's so rewarding. So I think I'm teaching them and reducing the stigma too, right? Replacing one drug with another. I hear from my own colleagues every day. So I think setting that example, teaching them, especially the new generations, I train a lot of students, and now the program's having that requirement, a lot of them, I think that'll be really helpful.
Bella, you have one more question right back here. Okay. He's been
We also have
very patient.
one over here as well. Sorry.
Thank you. I'd like to thank the panel for being here today. Very, very informative. So I'd like to address what really is an elephant in the room, and that is that it seems fine when we have a safe space of the hospital or a hospital clinic where we're offering things like medicine assisted treatment. But we talk about expansion of programs, and one of the things I hear over and over and over again is we don't have access to treatment programs, whether those are inpatient or outpatient. So we're talking about intensive outpatient treatment, we're talking about residential treatment. How do we, as people who are active in our communities and looked up to as either experts or community leaders, address the issue of NIMBY? Not in my backyard. We think that it's necessary to have all of these things, but we also have people out there who say, well, that's nice, but we need to do that someplace else. How do we address that to the population and the people that we interact with on a day-to-day basis to identify and get them to embrace the idea that we need these kind of treatment programs here in our community? Thank you.
I think from my experience at Hillsdale Hospital, it's persistence. I remember maybe 8 months ago bringing up sort of marketing the idea that we do MAT, and there was hesitancy around what does this mean? Will people be using in the waiting room? I mean, I've heard all sorts of things. And I just didn't let it go. I'm going to be doing this. I have a license to do this. I've already been doing it. And I think over time and education and them seeing how everything was going safe and how many people were helping, and now they're like, please go to this meeting today and speak. And I see the Hope House patients multiple times a week, and we've partnered with MAT services, and it's growing in the jail now, and they didn't have any services. So persistence, in my opinion, is where I've gotten anywhere with everyone.
Spreading the word. Spreading the word and making yourself heard. Even when people don't want to hear what you have to say, find a way to make them kind of listen. Education to the people that maybe don't want it in the community is key. The more they know about the drug, the more they know about the outcomes, the symptoms, the side effects, the pros and cons. I think the more people will jump on board. And maybe just having someone stand up that's been through mat treatment and expressing how much it meant to them and how important it was that they had it. That too.
Another avenue I think we're opening up is newer prescribers coming in not wanting to prescribe opiates. So we have a ton of people on maybe before Norco, morphine, any of it. And then we have new providers coming saying, I'm not going to be continuing this. And so now we're transitioning to Suboxone for a lot of those patients too that were dependent on opiates long term. And we know it's a lot safer, and local pain management clinics, Coldwater, Adrian, they're moving towards that as well.
Yeah, I agree with the sentiments here, and being open and honest about it. This has been a battle that's been fought for literally decades, if not hundreds of thousands of years. People use all over. It doesn't matter. Doesn't discriminate. Addiction does not discriminate. And so I think it comes down to, again, spreading awareness, having advocates, right? Having people that are willing to stand up and talk about these things, having difficult conversations, having people in positions of authority and power and influence. We've heard from judges today, we've heard from state senators today, we've heard from program, managers and things like that today. And so having this unified front, and this is why it's important for us to be coming together as a group like this, right? To get together, to share our ideas, to get on the same page, and all be willing to stand up for what needs to be done to treat substance use disorder and mental health disorder, so that we have better outcomes for our community, right? Because that's what the NIMBY thing is about. They don't want people breaking the law. They don't want people passed out or knotted out or whatever, or ODing, in their backyard. Yeah, me either. And so let's do something to change things so that people can get the help they need, that they can have a place to live, they can have food to eat. I don't know if people know Maslow's hierarchy of needs, but unless we get these base needs met, it's very hard for people to have more, conversations about, their life goals or their, whatever it might be. And so until we're willing to really address these issues that have been there for a long time, will continue to be there until we have a better system to address them, we need to keep fighting. We need to keep talking. We need to keep advocating for the people that have a hard time advocating for themselves. So.
Well, we could do questions all day, but we're out of time. So join me in thanking our speakers for sharing those resources.